Hello, future doctors. To jumpstart our respiratory critical care lectures, we start with knowing how to approach the patient with critical illness. The care of the critically ill requires a thorough understanding of pathophysiology and centers initially on the resuscitation of patients at the extremes of physiologic deterioration. So, this resuscitation is often fast paced and occurs without actually a detailed awareness of the patient's chronic medical problems. So while physiologic stabilization is taking place, the intensivist attempts to gather important background medical information to supplement the real-time assessment of the patient's current physiologic conditions. However, the intensivist must also be able to recognize when a patient's chances for recovery are remote or non-existent and must counsel and comfort the dying patient and their significant others. At this point, we must redirect the goals of care from resuscitation and cure to comfort when the resolution of an underlying illness is not possible. The illnesses that we encounter in the ICU are frequently categorized by degree of severity. So the scoring systems that have been formulated were eventually validated, and the more common ones, I will mention the three more common ones. The scoring system that would now give us an idea of the severity of illness will guide the hospital administrative policies. It could direct resources, whether it's nursing and ancillary care, and assist in the assessments of quality of ICU care. And for the clinician, it will complement the bedside decision making. But this severity of illness scoring systems cannot predict survival. So for the commonly used scoring systems, we have the Apache score, the simplified acute physiology score, and what we will dwell on for this session is the sequential organ failure assessment, which is the SOFA score. The SOFA score would assess the 6 organ systems, and these organ systems will be graded from 0 to 4 according to the degree of dysfunction. So the score accounts for clinical interventions, and this can be measured repeatedly, ideally each day, because rising scores will correlate well with increasing mortality. So the SOFA score has been used extensively among patients with infection, sepsis, and shock. It can also be, there's a shortcut to the SOFA score, and they call that the quick SOFA, wherein you just assess 2 or more of the organ systems. It could be the respiratory and the nervous system, or the respiratory and cardiovascular system, and a score of a minimum of 2 would give you a significant correlation with morbidity and mortality. So the quick SOFA, from the quick SOFA, we will be able to screen whether the patient who comes in at the ER is for ICU admission, or the patient who deteriorates in the wards is a candidate for ICU admission. So from the table 293-1 of Air Harrison's, we are given an idea of how to calculate for the SOFA score. The systems being evaluated are the respiratory system. Here we could count for the respiratory rate, or as shown in the table, we measure the partial pressure of the arterial oxygen divided by the fraction of inspired oxygen, that's in millimeters mercury. With a normal score of more than 400 millimeters mercury, the score is 0. However, with worsening hypoxemia, say at the start of ARDS, when the score of the PF ratio, when the value of the PF ratio is less than 300, you get the higher score. The other system evaluated is the coagulation system. We look into the platelets. The lower the platelets, the higher the SOFA score. The other system evaluated is the liver, and surrogate for this is the bilirubins. The higher the bilirubin values, the higher the SOFA score. For the cardiovascular, we measure the mean arterial pressure. So if the map is more than 70 millimeters mercury, that's good. Zero ang SOFA score. However, the moment the patient needs inotropes, it gives the patient higher SOFA score. And the more alert the patient, the lower the score. The more obtunded, the higher the SOFA score. For the creatinine, this is used to measure the renal system, or also a surrogate would be urine output, such that if the urine output drops below 500, higher score will be given to the patient. For the common conditions we encounter in the critical care unit of the hospital, we deal commonly with shock. It is defined by the presence of multi-system and organ hypoperfusion, and the clinical indicators would be a reduction in the mean arterial pressure, the presence of tachycardia, tachypnea, cool skin and extremities, acute altered mental status, oliguria, or hypotension. And when all this happens, you could be dealing with hypoxia or lactic acidosis, a consequence of the hyperperfusion of the different organs. In the initial evaluation of shocky patients, at the bedside, we should be able to assess whether there's adequate cardiac output. And if you try to judge whether you have a decreased cardiac output or an increased cardiac output, you look into the pulse pressure. So that's the difference between the systolic pressure and the diastolic pressure. If the difference is very narrow, and when you touch the patient, extremities are cool, and the capillary refill is delayed, then you are dealing with a decreased cardiac output shock. However, if the patient has a wide pulse pressure, pulses are bounding, and there's a rapid capillary refill, then there is increase in the cardiac output. Patients with signs of reduced cardiac output, we have to assess whether there's adequate intravascular volume, because inadequacy would mean that you could be dealing with hemorrhage on an actual volume loss, like as what we see in vomiting, diarrhea, and polyuria. And look at the jugular venous pulse of your patient, because this measures the right atrial pressure. But the change in the right atrial pressure as a function of spontaneous respiration is a better predictor of fluid responsiveness. So the hypotensive patient with increased intravascular volume and cardiac dysfunction would present commonly with S3 or S4 gallops, increase in the JVP, edema in the extremities. On auscultation, you could hear crackles or rowels. And when you get the chest radiograph, cardiomegaly could be demonstrated, or a widening of the vascular pedicle. Curly B lines could be seen. Pulmonary edema could be seen. And if the patient has ischemia, chest pain may be a presentation. When you assess the patient, you have to remember that the most common categories of shock would be hypovolemic shock, cardiogenic shock, or the high output with decreased systemic vascular resistance, or the high output hypotension. More than one category of shock, however, can occur simultaneously, so that in the initial assessment, as I've said in the first slide, it should only take a few minutes while you do your aggressive resuscitation, because this could greatly influence the survival of the patient. So the goal, however, that you should keep in mind when you do your resuscitation is to reestablish adequate tissue perfusion to prevent or minimize end organ injury. So in the diagram, in this same chapter in Harrison's, The approach to your patient with shock would again be guided by whether you are dealing with a low cardiac output or high cardiac output. So if the patient presents cold with clammy extremities, then most likely you have a low cardiac output shock. And then when there's increase in the JVP, crackles on auscultation, then the heart is full, or you are dealing with cardiogenic shock. So to this end, you evaluate for myocardial ischemia. And in this scenario, an echocardiogram or invasive vascular monitoring could help. And if the patient's BP has not yet improved with your resuscitation, start inotropes and afterload reduction. However, in a patient who has a low cardiac output but the JVP is decreased, the heart is most likely empty, and your shock here is hypovolemic, such that you may need to give intravenous fluids. However, the giving of the intravenous fluids may convert the low cardiac output shock into a high cardiac output one. But then again, when you're already giving your intravenous fluids and you did not appreciate any improvement, you may need to look for another reason for that shock. So consider adrenal crisis, the right heart syndrome, or pericardial disease. And again, to this end, you could do your echocardiogram and invasive vascular monitoring. So a patient with shock, and then you were able to appreciate warm skin, bounding pulses, then high cardiac output is a consideration. And high cardiac output shock is usually seen in sepsis or septic shock and patients with liver failure, such that the next step would be the giving of antibiotics and aggressive resuscitation. Another scenario that we will encounter in the critical care unit would be patients who go into respiratory failure, such that we have to be able to understand mechanical ventilatory support for such patients. So the principles of advanced cardiac life support should be followed during initial resuscitation. And you assess the airway when you do your ACLS. If a patient has hypoxemia, probably secondary to cardiogenic shock or pulmonary edema, or septic shock with pneumonia, or acute respiratory distress syndrome, then they may need mechanical ventilatory support. And the other indication for mechanical ventilation, if the patient could not blow off the carbon dioxide, which is what is seen in ventilatory failure. Once we initiate mechanical ventilation, this would now relieve the work of breathing and allow redistribution of a limited cardiac output to other vital organs. So the major goal is for the ventilator to assume all or the majority of the work of breathing. However, you should remember that upon the institution of mechanical ventilation as a support, shock may further decline. I mean, the mean arterial pressure may further fall once you start giving positive pressure. So the reason for this is the venous return could be impeded with the increase in the volume in your thorax. There could be a reduction in the endogenous catecholamines. And when you initiated the endotracheal intubation, you might have needed sedation, such that these drugs are also known to reduce blood pressure. Because we are now dealing with mechanical ventilation, it would be prudent to discuss the different kinds of respiratory failure. And type 1 respiratory failure is what is known as the acute hypoxemic respiratory failure. So this happens when the alveoli are flooded. The flooding could be from pulmonary edema, it could come from lung injury, or it could be because there's pneumonia or alveolar hemorrhage. The underlying physiology for the hypoxemia is the shunt physiology. So air could not go into the air sacs even if there's blood flow towards those air units. So patients with hypoxemic respiratory failure, the pulmonary edema could be categorized as those coming from heart failure and intravascular volume overload, where the edema is due to elevated pulmonary microvascular pressures, or the pulmonary edema could be secondary to a low pressure pulmonary edema that is seen in patients with ARDS. So ARDS usually has an acute onset that's less than 1 week of bilateral opacities on chest X-ray, and these opacities are not fully explained by cardiac failure or fluid overload. ARDS usually occurs in sepsis, in gastric aspiration, pneumonia, near drowning, or when the patient receives multiple blood transfusion. We refer to this as the transfusion-related acute lung injury or TRALE, and ARDS could also be seen in pancreatitis. The next kind of respiratory failure is what we call the type 2 respiratory failure or the ventilatory failure. This is a consequence of alveolar hypoventilation, and this happens when the lung is unable to eliminate carbon dioxide effectively. So why is it that we could not eliminate carbon dioxide? Maybe it's coming from the brain. So there's an impairment in the drive to breathe, which is common when the patient has overdosed. I mean, in substance abuse, drug overdose could produce this scenario. Otherwise, think of severe hypothyroidism. There might be a brainstem injury, or the patient could have sleep disordered breathing. The other reason why ventilatory failure could happen is if there is impairment in the strength of neuromuscular junction function, as seen in myasthenia gravis, in Guillain-Barré syndrome, in amyotrophic lateral sclerosis, and severe muscle weakness brought about by myopathy or severe electrolyte derangements and fatigue. Another reason for the failure in ventilation could be an increase in the load on the respiratory system, and the loads could be resistive. The load could be secondary to reduction in the lung compliance or a reduction in the chest wall compliance. So if there is pneumothorax, air goes out of the lungs but remains within the chest wall, then that would now reduce the chest wall compliance. The presence of fluid in the pleural space, that's pleural effusion, could reduce chest wall compliance. Or if the abdomen is very distended, then that now offers a chest wall, impede chest wall compliance. Now, lung compliance, on the other hand, would be reduced if there's edema in the alveolar sacs, if there's collapse of your alveoli, or in mechanically ventilated patients, if you have autopnea. There's resistance in the respiratory system if the airways go into spasm. That's bronchospasm, usually observed in severe asthmatic attacks or in exacerbation of COPD. So the mainstay of therapy for type 2 respiratory failure is reversal of the underlying cause of ventilatory failure, such that if you are dealing with bronchospasm, you give your bronchodilator. Or you could give the non-invasive positive pressure ventilation through a tight-fitting facial mask or a nasal mask, or sometimes the giving of a hood. Contraindications, however, to the non-invasive ventilation would be hemodynamic instability, if the patient cannot protect the airways, or if there is already respiratory arrest. Now, the third type of respiratory failure usually results from lung collapse or lung atelectasis. This is common in the perioperative period, such that the other name of type 3 respiratory failure is perioperative respiratory failure. This happens when there is a decrease in the functional compliance or the residual capacity that would now lead to the collapse of the independent units that happens after the giving of general anesthesia. This can be prevented or treated by frequent changes in position, by doing chest physiotherapy, upright positioning, and control of incisional or abdominal pain. So the patient would have that drive to take deep breaths. Again, treatment would be non-invasive positive pressure ventilation to reverse regional atelectasis. Now, the last type of respiratory failure is the type 4 that results from hypoperfusion of the respiratory muscles in patients with shock. Normally, the respiratory muscle consumes less than 5% of the total cardiac output and oxygen delivery. But in shock, 40% of the cardiac output can be distributed to the respiratory muscles. So we treat type 4 failure with intubation and mechanical ventilation so that we can now allow the redistribution of cardiac output away from the respiratory muscles to other organs. Because you now are instituting mechanical ventilation to your patients who underwent respiratory failure, you have to know how to care for your mechanically ventilated patients. Every time you do your rounds to these intubated patients, you should make a daily screening of their respiratory function. Now, if in your judgment the patient could not be liberated yet from the mechanical ventilator, you may give the patient sedatives. That way, you address their anxiety. The subjective dyspnea could be addressed. And if the patient is sedated, there would be a reduction of the autonomic hyperactivity. However, if the patient is in pain, analgesics is warranted, and the drug of choice here are the opiates. There are instances when you would be able to observe that the patient is not really in synchrony with the mechanical ventilator, such that if there is significant dyssynchrony, you are not relieving the work of breathing. So it might be prudent to do neuromuscular blocking for these patients. This could be achieved with cis atracurium. However, you must remember that if you do paralysis, there could be a post-paralytic syndrome that could persist for several days or weeks. The longer the patient is in neuromuscular blockade, the longer will be the duration of the myopathy. And if you decide indeed to do neuromuscular blocking, do not forget to put the patient on some degree of amnesia for comfort, because it would be very difficult for a patient not to be able to move and yet be so aware that they cannot move. So this is effectively achieved with propofol or benzodiazepines. And if you opt to give benzodiazepines, the choices would be lorazepam or midazolam. In your daily screen, you may want to look in, you have to look into the oxygenation of the patient, because this way, if you're able to demonstrate a good oxygenation, that's at least a PF ratio of more than 200 with a PEEP of less than 5 centimeters water, then the patient may be a candidate for a spontaneous breathing trial, especially if the patient's cough and airway reflexes are intact and you are no longer using vasopressors. And if the patient would pass the spontaneous breathing trial, then liberation from the mechanical ventilation could be done. Until then, you have to monitor the patient in the ICU, and the gold standard for us to be able to measure the pH of the blood, the partial pressure of the arterial oxygen tension, the partial pressure of your carbon dioxide tension, and the oxygen saturation All this could be measured directly if we do our arterial blood gas analysis. So in doing the ABG, we get to measure the two main functions of the lung, which is oxygenation and ventilation. And ABG is the only way to assess the blood pH. But you have to remember, every time you do the ABG, it's quite a painful process and expensive. If you're only after the oxygen saturation, the pulse oximetry could be used, and this is not expensive, non-invasive, such that it is now the most commonly used technique for monitoring respiratory function. In dealing with mechanically ventilated patients, try to understand some of the respiratory system mechanics. Look into the peak airway pressure, the plateau pressure, the airway resistance, the respiratory system compliance. Peak airway pressure is just really the airway resistance and respiratory system compliance, while the plateau pressure, which is a static measurement, is the pressure you get at the end of the inspiratory pause, and this is only affected by the respiratory system compliance. The airway resistance has nothing to do with the plateau pressure. So in effect, if you want to determine the airway resistance, it is actually just the difference between the peak airway pressure and the plateau airway pressures. So the respiratory system compliance is defined by the change in volume of the respiratory system per unit change in pressure. During volume-controlled ventilation, increases in airway resistance typically have increased airway pressures as well as abnormally high gradients between peak and plateau airway pressures. And the gradient could be more than 15 centimeters water. For the remaining topics in this chapter of Harrison, there's a bit of discussion about the prevention of complications of critical illness. And take note, especially because sepsis in the critical care unit is common, nosocomial infections is common, deep venous thrombosis is a common occurrence also, and nutrition could not be adequately addressed. Glycemic control should be very strict, and the longer the patient stays in the ICU acquired weakness could be observed. For the rest of these complications, I would leave it to you to review the remaining discussion in chapter 293 of Harrison's. Thank you very much for listening.